Very good evening. Can I start? So, my dear students, on this lecture, we are going to cover some of the important aspects of brain death, organ donation, and medico legal ethics. Now, since many of the participants are new to this sessions, in today's session, so I was told to give a brief introduction about a talk followed by a discussion of the MCQs. So, I will go through an understanding of the role of the ICU team in maintenance of potential brainstem donor. Now, this will solve many of your potential queries and will just instill you the confidence to understand that what exactly the ICU team has to do. And on this regard, it is good to know what are the important or the essential things that the intensivist is supposed to read about this in this situation. Right. So the objective in any patient, whenever there is a brain dead patient, is there is a shift in focus from optimizing cerebral perfusion pressure to maintaining the hemodynamic stability. And in order to do so, one has to be particularly attentive and careful to see that the physiology of that patient remains as close to normal as possible in terms of few things like the parameters like body temperature, oxygenation, preload, cardiovascular stability, and the urine output. Now, this will require some form of intervention or administration of drugs so that they maintain the physiology as much as close to the normal, which is not possible without support many times in patients who are brain dead. So, what are the pathophysiological changes and what is their clinical consequences that one needs to know? If you see that in case of brain death, if there is increasing ischemia, the hemodynamic affection will involve certain areas of the brain in increasing preponderance. The first is the pons. And in the pons, there is vagal stimulation and also sympathetic stimulation. So there will be bradycardia, there will be hypertension as a result of sympathetic stimulation, and as well as irregular breathing. Now, this triad constitutes the Cushing's reflex or the Cushing triad, and a clinical consequence of this is myocardial ischemia. So this one needs to know. As we move down, then the affection of the medulla occurs. In medulla, it is primarily sympathetic stimulation giving rise to adrenergic storm, which manifests as labile blood pressure to begin with, followed by vasoconstriction. And that also often involves or collides with the first phase of the Cushing's reflex. Now, the clinical consequences ventricular dysfunction and cardiac dysrhythmias. And when the spinal cord is affected, then there will be loss of this sympathetic output, which was the storm in the previous phase. There will be loss, so that will produce vasodilation and hypotension. Now, this hypotension is often viewed as a second phase of the Cushing reflex. So one has to understand that these series of changes are often mixed up. And because it is not necessary that the increasing ischemia affection of those centers in the brain is going to manifest in a linear fashion. And therefore, there is often a chance that the labile blood pressure may coexist with vasodilatation, and hypotension and bradycardia might also coexist together. But when it is affected, the spinal cord, there will be cardiac dysrhythmias plus pulmonary edema. So cardiac dysrhythmias can occur both in medulla and the spinal cord, whereas myocardial ischemia is more prominent with the affection of the pons and pulmonary edema with the affection of the spinal cord. So there are 7 areas of donor management which an intensivist has to hold forth with. One is the hemodynamic management, two, fluids and electrolyte balance, three, respiratory management, four, endocrine management, five, temperature management, six, anemia and correction of the coagulation factors if there is coagulopathy, and seven, of course, is the last but not the least important. It is one of the most important factors. It is the infection management. So if we can approach each of these parameters in a scientific manner as a point by point, then probably we are not going to miss any point. When we talk about hemodynamic monitoring, we include the minimum monitorings as these ones. One is the core temperature, two is the ECG, third is the systolic blood pressure, fourth is the central venous pressure. The arterial line, one has to place it, and that would be required not only to monitor the blood pressure, but also for the drawing the sample for ABG, the saturation, hourly urine output, and a POCUS 2D echo for assessing the cardiac contractility. By looking into those aspects, the VT, the Y, the velocity time integral, the ejection fraction, the RV function, diastolic function, etc., and also the assessment of the IVC. And we set up some targets and manage the patients with necessary drugs to achieve those targets. So this management includes short-acting agents for initial hypertension, then isoprenaline or adrenaline for decreased heart rate because atropine is ineffective. Ventricular tachyarrhythmias are treated with lidocaine or amiodarone, and circulating blood volume is restored by volume expansion, failing which one has to go for vasopressors and the ionotropes. So these are the various targets what is set in these patients for resuscitation so that the organs become salvageable and the success is achieved following the donation. So heart rate, the arterial blood pressure, cerebral venous pressure, urine output, serum electrolytes, and blood gases. Now you have to remember that each of these parameters can be used as a template to give you a case scenario from which questions can be twisted or framed in manner to to give you the answers or to check your knowledge about these targets. Next is the temperature. Temperature is a necessary criteria to pronounce brain death, and the factors which are responsible for this is loss of hypothalamic control, fall in the basal metabolic rate, absence of muscular activity, and increased heat loss from vasoplasia. The adverse effects are deranged intravascular coagulation, reduced myocardial contractility, and increased risk of arrhythmias. So, therapeutic temperature management includes the use of thermal blankets, reducing the passive heat loss, hot air devices, warm fluid infusions, and in extreme conditions, intravascular devices. The fluid management of the brain dead organ donor is also important because replacement of absolute volume deficits either by balanced salt solution or Ringer's lactate are the choice. Colloids are best avoided. 6% HES has been associated with a higher risk of delayed graft failure after renal transplantation, and hence should be avoided, and it is recommended to use multiple inputs to assess fluid repletion rather than indicating any, depending on any particular indicator. So the fluid management is the maintenance of 0.545% saline with 20 milliequivalent per liter of potassium to be administered and to provide both the volumes and electrolytes and replace the urinary losses. If the sodium is more than 150, shift to 5% dextrose, monitor urine output on an hourly basis, and increase in the maintenance fluids as and when required. It is critical to not fall behind the urinary output. So the donor management goals mandates that the heart rate, mean arterial pressure, urine output, LV ejection, PF ratio, the central venous pressures, and and the temperature should conform to these set guidelines. Now, wet or dry, if the donor's lungs are not being harvested, a fairly liberal approach to fluid resuscitation can be adopted. But if lungs are to be harvested, a cautious approach is required. Where the lungs are not being harvested, target CVP can be between 6 to 10 centimeter of water. Whereas if the lungs are harvested, a target has to be between 2 to 4. So again, you can see the crux that this information can be also used in the A type or K type questions to, or can be twisted, and the question can be framed to check whether you know this fact. Going to the respiratory parameters, the combination of raised hydrostatic pressures and the capillary damage in the pulmonary vascular imbalances, the Stirling forces across the endothelium, causes leakage of the plasma into the interstitium and alveolar spaces, which results in neurogenic pulmonary edema. The physiological pH, the targeting PaO2 of more than 100 millimeter mercury with the use of minimal FiO2, and an SpO2 of above 95% with a PaCO2 of between 35 to 40 is required. And lung protective ventilation attenuates the severity of the lung injury. So a protective ventilatory strategy bundles includes HERA positioning, limit excess fluids, diuretics if overloaded, tidal volume between 6 to 8 mils per kg of ideal body weight, PEEP equal to 8 to 10 centimeter water, plateau pressures less than 30, use a closed circuit for tracheal suction, and also monitor the chest X-ray, serial ABG, SpO2 with or without bronchoscopy if there are indications. The renal and electrolytes are important because we have to keep the targets of urine and maintain the normal electrolyte concentration, and have to monitor for that both the urine output and the serum electrolytes. And the management includes maintenance fluids. And if urine output is more than 4 ml per kg per hour, then can give desmopressin 1 to 2 mics or vasopressin infusion. The dose of desmopressin and vasopressin with acceptable urine output, that is of 30 to 200 per hour. The dose of desmopressin is 10 mics per nasal puff, or 1 to 2 nasal puffs every 4 hourly. Or vasopressin, you know that the dose is IV infusion at 0.5 to 2 units per hour. In terms of neuroendocrine system, posterior pituitary causes decrease in the ADH, so there is failure of urine concentration, giving rise to diabetes insipidus, and this is evident in 50 to 70% of during donor management. Anterior pituitary produces decrease in the T3, decrease in ACTH, and decrease in insulin, which leads to hypotension and cellular hyperglycemia. There is hemodynamic instability in a large number of patients, and also in a fraction there is metabolic acidosis. In the hypothalamus, there is loss of thermoregulation leading to hypothermia, and this accounts for nearly all the patients. So the management of endocrine dysfunction, again for pituitary failure, the anterior pituitary is more resistant than posterior pituitary. For diabetes insipidus, there is absolute deficiency of vasopressin, so we have to administer nasal puffs or IV vasopressin presumptively if 2 hours of urine output of more than 4 ml per kg hour have passed. Stop mannitol and Lasix if not done before. And vasopressin infusion is a rational choice because it achieves rapid correction of both hypotension and diabetes insipidus. So the diagnostic clinical criteria for central diabetes insipidus would be an increased urine volume and with the finding of more than 3 to 4 liters per day or more than 2.5 to 3 mils per kg per hour. Hypernatremia with a serum sodium concentration of more than 145 millimoles. Normal or increased serum osmolarity with a serum osmolality of greater than 305, and inappropriately dilute urine with the urine osmolality of less than 200 milliosmoles per kg or specific gravity of less than 1.005. Now, this is one of the very important steps one should know, the thyroid hormone replacement. So IV-T3 leads, that is a triiodothyronine, that leads to improvement in catecholamine responsiveness, better organ perfusion, and organ salvage rates. So consider if the ejection fraction is less than 45%. If IV triiodothyronine is not available, and its advantage is marginal when the patient is already receiving methylprednisolone and vasopressin. So what about corticosteroids? Methylprednisolone supraphysiological doses has been associated with decreased extravascular lung water, decreased level of inflammatory markers, and increased organ retrieval. So the dose is 15 milligrams per kg every 24 hours. Steroids to be administered only after sampling for tissue typing, since they may reduce the HLA expression. So this is also important. For thyroid hormone replacement, we have already covered. For hyperglycemia, we have to avoid extreme hyperglycemia, target sugar level between 120 to 180, and consensus guidelines recommended to treat at least severe hyperglycemia. And if you look into this hormone replacement therapy, you see the medication with regular insulin. If you put on a dose of 0.05 to 0.1 units per kg per hour of infusion, then it is quite appropriate. Recommendation is to monitor the blood sugar levels. With methylprednisolone, 15 milligram per kg IV or 1 gram IV every 24 hours, or 250 mg of IV bolus followed by infusion at 100 milligram per hour till organ recovery. And some studies have shown efficacy with hydrocortisone also. Levothyroxine 20 mics IV bolus and 10 mics per hour IV infusion. Vasopressin 0.5 to 1 millionits per kg per hour. And it has to be titrated with a mean arterial pressure of more than 70, with an our urinary output of 3 to 4 mils per hour, and with systemic resistance between 800 to 1200. Desmopressin 2 to 4 mics can be used in hemodynamically stable donors. For anemia and coagulation, for brain stem surge response, platelet activation, and dysregulation of the Vaud-Willebrand factor, activation of the coagulation pathway with increased fibrin formation and hypofibrinolysis. So naturally, it is to be considered as a prothrombotic state, contributing to the formation of microthrombi in the transplantable organs and potential deterioration of their function. So one needs to be very careful and should every bit of intervention to avoid that. Through thromboprophylaxis in the brain-dead donor, with patients with normal coagulation and platelets must be prescribed with low molecular heparin, and because of this coagulative state. For anemia and coagulation, there is no universal recommendations for RB and transfusion targets. So we target normally it is to maintain between 10 grams and consider RBC transfusion in case of hemodynamic instability with signs of tissue hypoxia. Now, severe thrombocytopenia could complicate the surgical procedures of organ procurement. INR of less than 1.5 and platelet count of more than 50,000 have been proposed as the therapeutic goals, including the transfusion of clotting factors and or platelets to achieve these goals before surgery. DIC in the donor is not a contraindication for transplantation, as it does not affect the long-term or even early graft function in the heart, lung, and kidney transplantation. For transfusion therapy, we have to withhold red blood cell transfusions until the HB falls below 7. There are certain specific infection prevention measures, like all unnecessarily indwelling devices should be removed. Invasive devices placed in suboptimal conditions needs to be changed using complete aseptic precautions. Antibiotics should be administered presumptively if there is a small evidence of infection till the cultures are available, and prophylactic antibiotics and nephrotoxic antibiotics should be avoided. One needs to be careful about bacterial infections, and antibiotics reserve the antibiotic therapy for treatment of either known or suspected infections, and screen cultures of blood, urine, and sputum at intervals consistent with general ICU practice and the patient's clinical status, so that we can able to detect or catch at the earliest if there is any deviation. So this following investigation should be performed at the minimum. You can see the CBC, the blood grouping cross-matching, coagulation profile, RFT-BUN, serum electrolytes, blood sugar, complete AFT, urinalysis, ABG with lactate, and cardiac evaluation, ECG, echocardiography, imaging, chest X-ray, ultrasound for abdominal organs, microbiology, surveillance cultures of ET, aspirate, blood, urine, etc., and as well as the vital markers, that is HBsAg, anti-HCV, and HIV1 and 2. The nutrition is also important because optimal feeding strategy for brain-dead organ donors remains, although it is unclear, but there is no doubt that it is important. It is unclear because clinical studies are lacking, And recommendation is to continue nutritional support as if brain death would not have occurred. So early parenteral nutrition in critically ill patients increases risk of infections and prolonging organ failure, and it is not recommended in potential donors. So there are certain medications which one needs to avoid, and primarily they are either hepatotoxic or nephrotoxic. In the hepatotoxic, there is a long list including most of the ATTs, then anti-HIVs, the anesthetic agents, colds, and this disease modifying agents that are used, the neurological drugs, and also the psychiatric medications. Among the nephrotoxic ones are the NSAIDs, diuretics, various cardiac drugs, antibiotics like the aminoglycosides, radiocontrast, and a lot of other drugs. The specific management of the brain donor includes communication issues. It is no doubt that this is the crux of the issue which can solve a lot of other problems. Provide time for the families to adjust to the fact that the patient's brain death and only proceed for counseling regarding organ donation. An ICU team which has conveyed the news of brain death should not be involved in counseling the relatives. So this is also an important point one has to note. So there are some absolute contraindications like age more than 85 and more than 65 for cardiac donation, primary intracerebral lymphomas or secondary intracerebral tumor, active cancer with spread outside the affected organ within 3 years of donation, melanomas, active hematological malignancy, definite, probable or possible transmissible spongiform encephalopathy, or individuals with relatives who have familial transmissible spongiform encephalopathy, tuberculosis, HIV disease, and of course, organ specific contraindications in the event of bacteremia or fangemia is not absolute contraindication to donation. The general nursing care is important because one needs to be careful to prevent any decubitus ulcers, take proper skin care, dressing changes, urinary and intravascular catheters, and catheter site care. All of these are important and should be kept in mind and done with a regularity or a periodicity as with a living patient. And this can prevent. It is also critical to actively warm the patient using either blankets or devices like forced warm airs and to monitor the core body temperature because hypothermia, which invariably develops in brain dead organ donors, can lead to coagulopathies and worsening of the hemodynamics. So, the take home message is that critical care management of potential organ donors is crucial in maximizing the number and quality of the transplanted organs. The goal is to provide adequate oxygen supply and tissue perfusion. Continuing care of the brain dead donor is often critical, difficult, complex, and may extend over several hours or even days. So, one need to be very patient and very focused to during this entire event. And prefer goal for successful organ donation is to maintain the hemodynamic variables and lab parameters within the normal range. So this was only a brief introduction and introductory lecture, particularly for those who are new in this group and who have not attended my previous lecture on the brain death, organ donation and ethics. And now I will move on to the main presentation for today, for your exam purpose so that you can pick up or you can try to understand the relevant areas from which questions can be framed or questions are more likely to be picked up. Now, this is important for exam purpose. First of all, what is brain death? This is a simple, this definition by WHO is sometimes forgotten, but this one should always remember. And this definition has been changed. Many things have been changed, but this definition has not changed since 2009, where it has been defined as an irreversible cessation of cerebral and brainstem function characterized by absence of electrical activity in the brain, blood flow to the brain, and brain function as determined by clinical assessment of responses. So a brainstem person instead, although his or her cardiopulmonary functioning may be artificially maintained for some time. So this includes that the stepwise the role of the different parts of the brain, the cerebral hemispheres, which is indicated in the figure as cerebrum, which is responsible for language, memory, emotion, voluntary movement, and cognitive abilities, and brainstem, which controls breathing, heart rate, blood pressure, and the level of consciousness. So these three conditions must be confirmed to declare brain death. One, the patient is in persistent coma, patient has no reflexes, and patient cannot breathe without assistance. So no breathing for 10 minutes without mechanical ventilation is one of the criteria which comes under this category of patient cannot breathe without assistance. So whenever you suspect irreversible brain damage, if you follow this flow diagram, you will be able to understand the line of approach. And this is also very important to understand this line so that it becomes easy to solve the questions which provide various clinical scenarios with different procedural steps. So once you know the neurological steps and you see, check the brainstem reflexes, you determine whether the brain is irreversibly damaged or not. So you discuss upon the treatment futility or in-fast prognosis, identified as medical suitable for organ donation, consultation of the donor register, and patient register refusal, then you don't approach. Otherwise, you approach family members. If family refuses, then otherwise you take consent for organ donation, determine brainstem, the brain death, and that is determined by formal brain death or the brainstem reflexes, e.g., apnea test, etc. And if the brain death is not determined, he is a potential NHB donor. If brainstem is determined, brain death is determined, then is a heart beating organ donor. So these are the various vital signs and general criteria that I had discussed in my previous PPT, but here it is more or less in a uniform as a single page it is reflected. So first you listen what should be the core temperature more than 36, SBP more than 100, absence of drugs that could simulate brain death. So one has to be sure that the patient has not been on any of these drugs of recent, and absence of brainstem reflexes, either in the form of fixed pupils, absent corneal reflexes, absent oculovestibular reflexes, absent oculocephalic reflexes, absence of gag, cough, etc. So all these are important, and absence of any cerebrally mediated response to the auditory and tactile noxious stimulation and in the peripheral and in the cranium is important. So stimulate areas like supraorbital ridge, no limb movement, no eye movement, or no facial movement, again takes us to this pointer. Then apnea confirmed with apnea challenge, and if there is no respirations with PCO2 of more than 60 millimeter of mercury, so then becomes a criteria. Now coming on to some of the A-type questions, you can see 30, and you can unmute yourself and answer when I ask you these questions. So then we can discuss. A 30-year-old man who had traumatic brain injury was declared brain dead. He is a potential organ donor and he progressed to shock. What would be your next appropriate step? A. Administer methylprednisolone, which is associated with increased organ retrieval and should be done as soon as possible. Myocardial ischemia is a common complication and all donors require angiography. Noradrenaline is the vasopressor of choice as it increases the vascular tone, and triiodothyronine, that is T3, should be administered immediately in brain net to prevent vasoplegic shock. So what is, you can just unmute yourself and try answering. Anybody?
Sí,
Okay, you can type in the chat box. Who said C?
Sammy.
So the answer is actually A.
Okay.
You have already see that administer. I have discussed it in during the PPT that administering methylprednisolone is associated with increased organ retrieval. And if you see, vasopressin may reduce catecholamine requirements, and it is the vasopressor of choice. So here in this choice, it was noradrenaline. MI is not common complication, but needs to be considered in patients having risk factors for MI, and screening echo suggesting regional wall motion abnormalities. Not all donors will require angiography, but it may be considered in those with heart donation or those who are heart donors. Then T3 can be considered in case in to reverse hemodynamic stability, but not as a prophylaxis. So if patient is hemodynamically stable and you think that there is no need to give a T3, then you should not, because it has no prophylactic role. The corticum study showed no beneficial effect on graft recovery despite reducing the need for vasopressors in donors receiving hydrocortisone alone, but observational studies have demonstrated improved hemodynamic and oxygenation. So, despite mixed results, steroids are widely utilized for organ donor resuscitation.
So, sir, that patient was already in shock.
Yes, yes.
Yeah. So, next, sir, the explanation has said that you should give levothyroxine in patients who are hemodynamically unstable.
Yes. So, but the next appropriate step would be you have to give only one response. So, in that case, first you have to say methylprednisolone, right?
So this patient is in shock due to neurogenic shock or septic shocks.
No, no, it is progress to shock. You have to consider it as your neurogenic shock. Why you have to consider septic shock? Septic shock is only one fraction will only have. So you will have to ensure that the organ will become salvageable. So that is your first consideration. So first step is administer methylprednisolone. Of course, T3 has to be given, but it will come next down in the order. The first will be this. Next, see another A-type question. You are attending physician in an ICU, 45-year female who is a potential organ donor was brought to your ICU for hemodynamic monitoring and optimization, which is a false statement here. One, initiate sedation to stabilize BP and prevent shivering of the patient. Two, lung protective ventilation strategy with a tidal volume of 6 to 8 mils per kg with optimal PEEP and minimum FiO2. C. Tracheal cuff pressure to be maintained at 25 centimeter water and head of bed elevated to reduce the risk of aspiration. And 4. If vasopressor drugs require vasopressin 0.4 to 2.4 units per hour can be used to reduce the catecholamine requirements. So what is false? Anybody? So this is the answer is A. That is initiate sedation, because you can see by exclusion also lung protective ventilation, tracheal cuff pressure, vasopressor drugs, these all seem reasonable. But you have to know that you have to stop unnecessary drugs. You have to, patients is on sedatives and all, you have to stop them. So that is why important. You don't have to administer, and reduce heat loss and actively warm if the necessary to maintain the core temperature of more than 35 degree centigrade. So this is important, and this reducing the heat loss, that so, and lung protective ventilation is one. It is important because this should be maintained. Tracheal pressure of 25 centimeter of water and nursing with the head and belt to reduce the risk of aspiration. This is a part of the normal care. And if vasopressor drugs are required, vasopressin 0.4 to 2.4 units per hour may reduce catecholamine requirements, and high doses of catecholamines like norepinephrine should be avoided if possible. If urine output is more than 4 mils per kg per hour, consider the diagnosis of diabetes insipidus we have discussed, and we have to treat with vasopressin infusion or desmopressin. So here the answer is A. Another A-type question, which among this is not an essential component of brain death? A. Irreversible coma due to approximate cause, absence of brainstem reflexes, irreversible apnea, and absence of spinal. Anybody?
D.
Correct. It is D. Absence of spinal reflexes, because you know that brain death is equivalent to death despite the maintenance of an heartbeat and spinal cord function. And the diagnosis of brain death demands proof of irreversible loss of consciousness, brainstem reflexes, and the ability to breathe. Now, how to perform apnea test? This is also an important aspect, and you can expect questions centering around apnea test: when to do, when not to do, how to do, etc. So vasopressor should be adjusted to maintain a systolic blood pressure of greater than equal to 100. Pre-oxygenation is given at least for 10 minutes with 100% FiO2 to a PaO2 of more than 200 millimeter mercury. Reduce the ventilator frequency to 10 breaths per minute. Reduce PEEP to 5 centimeter of water. If the SpO2 remains more than 95%, obtain baseline blood gas. disconnect the patient from the ventilator and preserve oxygenation with oxygen delivered through the insufflation tubing at a rate of 6 liters per minute at 100% FiO2 near the level of the carina through the ET. Look for respiratory movements for 8 to 10 minutes. Repeat blood gas at approximately 8 minutes if no respiratory drive is observed. If no respiratory movements are observed and the PCO2 more than 60 millimeter of mercury or 20 millimeter mercury increase in PCO2 over the baseline, apnea result is taken as positive. So this is a brief. I have framed it in a serial way so that it is easy for you to remember the steps. And once you can visualize these steps before you, then you will be able to answer any question. So if this above list is complete and coma, the absence of brainstem reflexes and a positive apnea test are present, the diagnosis of brainstem death can be made. That, of course, I have said before. Now, when should we abort the apnea test? Any respiratory movement like abdominal or chest excursions or brief gap, if it exists, we have to abort it. If the systolic blood pressure decreases to less than 90, and if the oxygen saturation is less than 85% for more than 30 seconds, in that case, the procedure has to be retried with the TPIS, maintaining a CPAP of 10 centimeter of water and administering oxygen 100% at 12 liters per minute. So these are the steps which one has to remember while understanding the apnea test. Now, again, another A-type question. You are a medical officer treating a patient and a team member who is supposed to certify brain death. Identify the false statement. 1. Treating doctor should not be a part of the brain certification team. 2. Etiology of coma or irreversible brain damage should be known. C. An observation period greater than 4 times the half-life of the pharmacological drug which confounds assessment should be used. And 4. According to the THOTA, that is the act which guides this transplantation in India, the only legislative acts wherein brainstem certification procedures have been laid down. So which is false here?
C, 5 half-life times.
Let me check. Someone has written A. Okay. Someone is saying C. So the answer is A, because treating doctor should not be a part of the brainstem certification team. This is false. Treating doctor can be and should be part of the brainstem certification team. So, and it is suggested to wait for a greater than 4 half-life, 4 times the half-life of the confounding pharmacological agent before proceeding to assessment for brainstem function. For example, if someone has administered relaxants, sedatives, morphine, etc., then one has to wait for that time. And THOTA is the only legislative act in India where brain death certification procedures are laid down. So other countries have their other roles. So whichever the exam you are giving, based on that country's act should be known to you. Now, this I have already put down, but this is another presentation which I had made for another group. So here we actually, you can see what are the recommendations. These recommendations are based on most of the common recommendations which exist for all the countries like India, Australia, UK, and US. And this is the general management as well as in the monitoring regarding the steps which one need to do in following up patients with brain death for organ transplantation. And the therapeutic target which I have mentioned earlier is same. So this is a common thing. The other important things that one needs to know is about that with respect to the non-transplant organ retrieval centers, which is a false statement. A, they are permitted to certify brain death. 2, any director of health service of registered hospitals having a facility of OT and ICU can be defined as a non-transplant organ retrieval center. They can perform organ retrieval or they can permit it to perform transplantation. So it is simple that they are not permitted to perform transplantation. The name itself suggests, but many a times these are googly questions. It was asked in one exam. Some people thought that probably in exceptional cases they can perform transplantation, but no, this is wrong. You don't think you have to think that way. They are not entitled to perform transplantation. They are only entitled for retrieval, come whatsoever. So these centers are under the Director of Health Services of the state, of the registered hospitals which are designated to certify brain death. So their permission is for certification and perform organ retrieval. Now, again, I'm giving another question. A 56-year-old man who suffered from hypoxic brain injury was declared brain dead on the 7th day of the ICU stay. Family requested voluntarily for organ donation. He was evaluated further and CMV antibodies were positive, IgG. He had childhood history of lymphoma and had completed treatment. He had purulent tracheal aspirate and a fever of 101. His bile cultures yielded Acinetobacter, which was sensitive to meropenem. He was initiated on culture-based antibiotics. His PF ratio is 340. Which of the following statements is true? I hope you get the picture. His lungs were not suitable for transplantation due to infection. B, positive CMV serology in the donor will adversely affect the patient and graft survival. C, presence of any malignancy is a contraindication for transplant. And D, after appropriate antibiotic therapy, organ retrieval is possible even in a septic donor.
B, sir.
So the answer is D actually. After appropriate antibiotic therapy, organ retrieval is possible even in a septic donor. Positive CMV, HSV, or Epstein-Barr virus serology is not a contraindication to donation, and with chemoprophylaxis for CMV outcomes are similar. Tumors with low degree of malignancy or localized neoplasms are not contraindications for transplant, and after antibiotic therapy, organ retrieval is possible even in a septic donor who are hemodynamically stable or tapering vasopressor therapy. Even lung donation is possible with adequate antibiotic. So this is one question which was asked in an exam a few 4 or 5 years back. So one should be careful while answering such questions. Let me answer some K type question, that is yes no type question. Indicate true or false state regarding the persistent vegetative state and brainstem death. A, persistent vegetative state results from damage to the cerebral cortex. B, in brainstem death, damage to the ascending reticular activating system leads to a sense of deep, persistent, and deep coma. C, spontaneous respiration is absent in persistent vegetative state. And D, cranial nerve reflex will be absent in persistent vegetative state. You can answer like true, false, false, true, or true, true, false, false, something of that kind. You know about the K type. So it is true, true, false, false. Persistent vegetative state results from damage to the cerebral cortex is true. In brainstem death, damage to the ascending reticular activating system leads to a state of deep persistent coma. That is also true. But spontaneous respiration is absent and cranial nerve reflexes will be absent is not true. So persistent vegetative state results from damage to the cerebral cortex with intact brainstem, and hence they are preserved, the cranial nerve reflexes, and brainstem death is secondary to irreversible damage to the brainstem, and hence both consciousness and cranial nerve reflexes are absent. So this is how you have to go for the. Now again, another K type of question. Indicate true false regarding the apnea test. Apnea test is mandatory test to establish brain death. Aim is to test for hypoxic respiratory drive. Pre-existing respiratory illnesses like COPD is a contraindication for performing the test, and respiratory-like movements such as shoulder elevation and adduction, back arching, intercostal expansion without tight significant can be observed during the apnea test.
ETFT.
Okay. It is FFFT. So apnea test is not mandatory. So you see that it is not mandatory, but desirable test to establish the brain death. In cases like severe lung injury where hypoxemia is pre-existing, apnea test is not feasible. Then one should choose for the ancillary test, CT, angio, TCD, etc. So apnea tests the hypercapnic respiratory drive, not the hypoxic, because you always look for rise more than 60. Apnea test can be performed in most cases of COPD because here the target elevation of PCO2 will be more than 20 millimeter mercury from the baseline. It will not be as 60 as for non-COPD patients. And respiratory movements like Lazarus reflex have been observed during the apnea test even when, especially when patient becomes hypoxic. So these movements can occur naturally or normally. So that should not be a bar. So about the medication protocols, this you need to know a bit the theoretical part, because this can be some one-liner questions, or in a question they can be twisted. Some of these, like what should be the short, because the short-acting antihypertensive drugs should be used for hypertension. In hypotension, restore the circulatory volume, use vasoactive agents. So here you know more or less the it remains same as we do it in other patients, but you can see in terms of electrolytes there are certain specific medication protocols, like what to do in case of sodium more than 180. You give point for 4-5% saline 300 ml per hour, or 5% dextrose as in the IV. If it is between in 160 to 180, you reduce it to 200. So likewise, these are some of the numbers which are sometimes important. Same about the hyperglycemia, hypoglycemia, steroid replacement. I have already mentioned it during my previous PPT as to how you have to move on. And also regarding mucolytic agents, anti-ulcer agents, and antimicrobials, they have some role one needs to know. Like, look into another K-type question. Indicate true false regarding ancillary tests for determining brain death. A. Ancillary tests can be used as an alternative to clinical neurological examination. B. Lack of TCD signals cannot be interpreted as confirmatory of brain death. C. In conventional CT angio of brain death patients, there will be absent arterial blood flow in both external carotid and the internal carotids. And D. EEG can be isoelectric in patients with preserved brainstem reflexes. Anybody can attempt? Someone has made
False.
it EFT.
False, true, false, false.
False, true, false, true. So last one is true. EEG can be isoelectric in patients with preserved brainstem reflexes. See, confirmatory tests are optional, as you know. In most guidelines, they are reserved where clinical diagnosis of brain death, including apnea test, cannot be completed or is doubtful. Lack of TCD signals cannot be interpreted as confirmatory of brain death because 10% of patients may not have temporal insonation windows. EEG does not demonstrate brainstem activity. It can be isoelectric in patients with brainstem reflexes who are clearly not brain dead. Brain dead confirmation by demonstrating the absence of intracerebral filling at the level of carotid bifurcation of circle of Willis, and external carotid circulation is patent, and filling of the superior sagittal sinus may be delayed. So this is the reason why EEG does not demonstrate brainstem activity always. So this is one which you should keep in mind. Again, another K-type question, indicate true false regarding donation after cardiac death. Now, this is something that you have to understand. And if you read the Samuel, the book of transplantation, here you can see those charts which have been given one needs to follow during cardiac transplant. So this is a important. Warm ischemia time is a time lag between treatment withdrawal and cold perfusion. Donation after cardiac death kidney grafts were far inferior to donation after brain death. Warm ischemia time is a key determinant to successful transplant outcome. And DCD heart grafts are difficult to use because of unavoidable warm ischemia time. Any attempts? So here it is true for all the except B are true. So the DCD kidney grafts were far inferior to that of donation after brain death, DBD. So this is the false statement here. And because all of the studies and all the researches so far has shown that they have equivalent survival. Another K-type question, in the donor infected with HIV was considered as an absolute contraindication to organ donation. Presence of any CNS tumor is an absolute contraindication to organ donation. Liver or kidneys from HCV positive donors may be transplanted to HCV carriers, and donation of organs is not a contraindicated for donors with past history of melanomas.
True, false, false, false.
True, false, true, false. Well, that true, false, you said third one, you said true or false?
False or true.
Okay, so it is true, false, true, false. So Again, if you see, infection with HIV was once considered as an absolute contraindication until recently. A series of patients had undergone and they had a good satisfactory outcome. And donation in cases of tumors with low degree of malignancy or localized neoplasms is acceptable. This includes skin tumors like basal cell and squamous cell carcinoma, not melanomas, of course, carcinomas in situ, primary CNS tumors, etc. And therefore, the rest is very evident naturally. So it's clear. Another K-type question. This was asked in one exam. Autonomic storm with hypertension tachycardia is due to brainstem compression. Bradycardia following brain death usually responds to atropine bolus. Hypernatremia is associated with poor liver graft function, and TSH secretion ceases and thyroid hormone becomes depleted rapidly within 12 hours of brain death.
False, false, true, true.
True, false, true, false. So here also you see that sympathetic storm with hypertension bradycardia is due to brainstem compression. So there is no doubt about that. If bradycardia develops, it is usually does not respond to atropine. I mentioned you, it will have to administer adrenaline. And hypernatremia to be avoided, and it has been associated with poor liver graft function. So hypernatremia has to be avoided at all costs by administering free water and or 5% dextrose. And the risk of graft loss is 3 times higher if the sodium is more than 155. And TSH secretion ceases, but thyroid hormone becomes depleted only after 24 to 48 hours. So you have to remember that it is not 12 hours, it is 24 to 48 hours. So this is an important. So this is roughly about the different phases, different types of the background on which you should know, understanding brain death, organ donation, what to do in patients who are to undergo donation, what are the steps one need to follow during diagnosis, certification, and also the management. So if you have some idea of whatever I have discussed, I think you will be able to answer all the questions from this area. The second part of today's lecture is ethics. In ethics, you shouldn't expect too many questions, but it will be your common sense you have to apply, and certain basic things, if you know certain facts, then they are all sitters for you. That is, you don't miss a single mark. So these are the 4 pillars of medical ethics. You have to always remember: autonomy, beneficence, non-maleficence, and justice. Autonomy means respect for patient as an individual, respect patient's decisions. Beneficence means do only good. Non-maleficence means do no bad. And justice, treat everyone equally and within the law. So if you remember and try to understand and apply your mind to these 4 things, you will be able to answer the common questions, because these 4 principles represent a framework for analyzing the best action in a given situation. And most of the questions are from this section will be situational context, will have a situational context. Our patient has a serious illness and is about to undergo surgery. Just before anesthesia, she asked, "Doctor, will I be okay?" To which I said, "Yes, of course, even though I'm not sure about the outcome." But the surgery was later proven unsuccessful. Which of the following statements is true or false regarding the medical ethics? My action is in violation to the code of ethical conduct. My action is not a violation as it fulfills the consequential ideology. My action is not a violation as it is not recorded or written in the file. And my action is not a violation as long as there is no complaint. What do you think? This is a situational. So the answer is B. So my action is not a violation because it fulfills the consequential ideology. So you have to understand what is consequential ideology. Now, consequentialism, a term which is a technical term, it is an ethical ideology that states the morality of an action is dependent purely on the consequences. So if the consequences is actually, if it has to be good, the morality is then this is not in violation. So it was all in good intent. Suppose another question: you have a sum of money to either fund a very expensive treatment for 1 patient with a rare disease and 5 patients with a very common and easy to treat disease. You chose to treat the patient with rare disease because he approaches you first. Which of the following statements is true or false with regard to medical ethics? A, you have violated the utilitarianism in ethics. You have not violated because easy to treat disease can recover on its own. C, you have not violated because there are no guidelines to follow. And D, you have violated because consent was not obtained from the relatives of patients with common disease before treating the one with rare disease. Again, you can see this is again a situational question. Utilitarian ethics, because it indicates that treating the five patients is morally superior as it has a greater overall benefit than achieved. So therefore you have violated the utilitarianism in ethics. So if it is you have chosen to treat the rare disease at the expense of not treating the five patients, so then that leads to violation. So if you once the previous one was consequentialism, so this one is about utilitarianism or utilitarian ethics. 3, if a terminally ill patient asks if they'll be okay after surgery, they're likely to survive, a dash approach would suggest you don't lie just to comfort them. That's because, according to this concept, lying isn't morally acceptable because it's our obligation not to lie, no matter whatever the consequences are. Now, this is also another uh, ideal, this concept, this logic. So, what is it? So, like in the first question, I talked about consequentialism, and second about utilitarianism. Non-maleficence, I have already do no harm. So it is deontology. So deontology is that concept which means that your morality of action is based on whether you followed the rules rather than the consequences of which was followed. So this is in contrast to consequentialism. In the first instance, if you remember, the patient died, although you were not sure, you said that you were all right, you will become all right, and the surgery was not all right. But you're not, as per consequentialism, you were correct. But in this case of as per deontology, you will be wrong. So you have to remember that most of the ethical standards in the courts of across the world, whether India or US or UK, they follow consequentialism, not deontology. Deontology was followed for a brief period of time there during Second World War, but later it was dropped. So, but you have to know the meaning and the context of deontology. Third important questions that sub arises are with the clinical trials registry. For at least for Indian exams, you should know this, and for the other countries also, because a lot of ethical violations had taken place some 10 or 20 years back during clinical trials, and every country became very cautious about the ethical guidelines and how to protect the interest of the patients or those who are participants in the trial. And this you have to follow as per the exam that you are taking for whichever country. For India, it was launched in 2007 by the ICMR, and in 2009, the Clinical Trial Registry of India, that was made mandatory by the DCGI, that is the CITSCO, and for trials that are registered under the Drugs and Cosmetic Acts and its rules. Registration with CTRI is voluntary for other researches like biomedical and health research, etc. But if there is an exchange of biological material between the collaborating sites, then the ethics committee require permission from the respectable authorities. Now, this is also another important question. Every country has its own framework. For India, that it is the rule is that all records must be archived for a period of at least 3 years, and documents related to regulatory clinical trials must be archived for 5 years. So a timeline is there. You cannot disload these documents. You have to preserve it. And ethics committee should have an archival and retrieval mechanism so that even after 2 years, if someone asks and wants to check that whether any ethical violation has taken place or not, you can show all the documents at your disposal to satisfy him. And these records should be accessible for inspection by the authorized representatives of the respective agencies. Now, this is one important thing, but this is similar between India and UK. So those who are taking UK exams, if you follow your NICE guidelines, you will find the same chart. It is followed that any serious adverse effect within 24 hours of occurrence should be reported by the principal investigator, and within 14 days of this occurrence, final report by both the investigator and sponsor should be submitted to the regulatory authority. So this timeline, 24 hours for reporting and 14 days for the final report, stands same for India and UK, if you see. In addition, the DCGI also has, this is for India, this part, recommendation on causality and final order on the quantum within 90 days of receipt of a severe adverse event. So that is the part of the regulatory agency. So of course, doctor doesn't have a role in it, but the agency has to, and they will tell the sponsor to pay the compensation or the patient's relative within 30 days of this receipt of this order. So 14 days here, 3 months here, and after that within 1 month. So it is the responsibility of the investigator to report all these serious adverse events to the sponsor and the ethics committee within 24 hours of its occurrence. So this is important, one should remember. So this is all we can have to discuss for today. So if there is any question, I can take. So thank you very much all. Hope you have taken the necessary tips and the messages from today's lecture. If you at later stage you need any queries, you can always mail it to the academy and they can forward it to you further. So thank you very much. Good night.